Good morning. Let's start this session, and at first I'd like to say thanks for our friends here, Gerard Prager and Jerome Darjan, by the possibility to have this session. This will be an Ifso session in partnership with Ifso European chapter. And I think we have a nice session because we will have the best of our faculties here. There is no presentations. They will not be comfortable presenting something. We have something that will be new for them. I don't have any disclosure to present here. And this will be based in decision making. We will have some cases, and let's see how they think. We have the discussants, Professor Prager and Professor Grieve. David Noka will represent here sleeve gastrectomy. Professor Suter will represent Renai gastric bypass. Chevalier, one anastomosis gastric bypass. Amador Garcia, one anastomosis duodenal switch. And I think that Patu is coming. Patu will have the opinion of the researcher in these situations. Let me remember you the size of Ifso. Ifso is right now a federation of 65 societies. I think that up to Madrid we'll have two more, will be 67. And we have, besides the 65 country societies we have more surgeons coming from 30 different countries that we don't have Ifso societies in these countries. It's close to 10,000 members, and we have 5 chapters: Asia Pacific, North America, European, Middle East, North Africa, Latin America. These are our vision and our mission. We have a lot of benefits to being a member of Ifso. And particularly this year, we have worked in different situations. One that is working hard with social media. And for you that are not involved with that, I advise you, join us. We have a lot of our educational activities. This is one of them we did in January. You can see here Chevalier was involved in this. That was about weight regain. So this is our Ifso Virtual Academy, our webinar. Every month we discuss one case published in obesity surgery. This is a new project that is the Ifso Cookbook. It's a book of receipts that we will collect and present in Madrid. And we will have one of Spanish chefs working with us in this project. This is the training center we had in Dubai. You can see it was a huge training center. We are working to have a biggest one in Madrid. We believe in training, so this is the simulation and advanced training center. We have a kind of situation like this for Madrid. We are working in an application to training. This will be our towers of training we will have in the centers. This is another activity, is the Ifso video case reports. Every month we publish 8-10 different cases, peer-reviewed, and we discussed with our members. We have discussed a lot here in Lyon, the Ifso registry. We have right now the version 4. Will be the version 5 will be presented in Madrid. As you see, we have right now collected 850,000 patients. We will be the best collection of patients in bariatric surgery so far. And we are trying to receive more and more. So if you have any data to send us, please send to be presented in Madrid. This is our journal. We include 2 more associated editors representing more chapters. We include more 25 reviewers. So we are trying to have a quick process of approval. If you don't know all of these 8 magazines, you know for sure obesity surgery, but being a member of Ifso by our website, you can access any of these magazines. They are totally free for our members. So we have Surgical Endoscopy, Journal of Eating Disorders, Diabetology, Eating and Weight Disorders, Journal of Diabetes, Nutrition and Obesity. That are really good magazines and are totally free and accessible for you. If you don't have, go to Apple Store or Google Store, Google Play Store, and download the application. This is the application of Ifso that we have very easy access from your smartphone. It's very, very simple. Just go to your store in your smartphone and download this. Reinforce the invitation to Madrid. We had 1,300 abstracts submitted. It's a record in Ifso. Remember that you have discount in the registration, and we decrease the registration fees for this year, mainly for integrated health and resident students and young Ifso. This is some new activities we have in Madrid for the first time ever. So we have a session with operated surgeons. Just surgeons that had bariatric surgery. So you have the chance to ask for a surgeon that you know that defend a lot Roux-en-Y gastric bypass, but in the moment he decided to have a bariatric surgery, he asked for a sleeve gastrectomy. Ifso Talks in the same model of TED Talks, a session dedicated to women in bariatric surgery, a session with the ERA Society, a full room dedicated to bariatric cinema, just videos, videos in 3D also, a session about bariatric beyond the border, that is about tourism, medical tourism in bariatric surgery, the Advanced Training and Simulation Center with the opportunity to train endoscopy, robotic, and endosuture, session with IBC and BEST. We have the biggest registry ever. We have the launch of some books and the bariatric bullfight session that is will be a big surprise for you. But let's work with our faculties here. So, David, you have a microphone here. You can use the microphone. You have 2 minutes to convince us that sleeve gastrectomy is the best procedure. Yes. This one, yeah.
I have to face to...
Just talk. Why sleeve gastrectomy is the best bariatric procedure?
As I told yesterday, I have to... it doesn't work? No, it's okay, sorry. As I told you yesterday, I think the choice of the procedure, it's a balance between benefits and risk. And today, I'm still convinced that even if we have complication as GERD in the long run, sleeve promotes, and we have seen it with the randomized study from Paulina and Ralph Peterli, a long, good success. I mean, the excess weight loss at 5 years is quite the same than the bypass. We have good effects in terms of comorbidities management. I think in case of trouble, we can propose another operation. I mean that it's different than for bypass and Roux-en-Y bypass. If you have a failure with bypass, you really don't know what you have to do. Another point is that in France and in my team, we have at 5 years a lot of loss of follow-up. And that's why I don't promote the malabsorptive operation in my team. And I have to be honest, I have the data for the French registry. Last year, less than 200 malabsorptive operation. I don't speak about omega, which is for me a small malabsorptive operation. But SADIs, duodenal switch, BPD, less than 200. Why? because we are afraid of the complication, and in the long run, I think it's not so easy to manage. So for me today, the best operation and the best balance, benefits and risks is sleeve.
Okay. Thank you. Professor Sutter, please, you have to convince us that the best bariatric procedure is the Roux-en-Y gastric bypass. And in the end, let's see who convinced it more. Let me hear from Professor Jan Grief and Gerard Prager if they are convinced by you. So, 2 minutes.
Okay. I think there's no best bariatric procedure. There's a risk-benefit ratio that you need to take into account for each procedure. And overall, for the average patient, I'm convinced that the Roux-en-Y gastric bypass is the best choice, even though it's maybe not the only option. It's been on the market for 15 years. 50 years, we know how it works, at least the best we can. We know how to fix the problems. We also know how to prevent most of the problems. One big issue is, of course, the internal hernia problem, and we have learned that carefully closing the mesenteric defects can really prevent them, even if not to avoid them completely. We know about the long-term results. There are now several papers published with 10+ year results, which show a good effect on both weight loss maintenance and correction of comorbidities, even in the very long term. We have the results, and this is something we don't really have for sleeve gastrectomy, for instance. It's a relatively new operation. We know of some of the drawbacks of sleeve gastrectomy, like the reflux. We don't really have lots of data about the long-term results regarding comorbidities. We start to have 5-year results, but we need longer-term results. We have to keep in mind that we operate on very young patients. On average, they're 40 years of age. And if we have them face an operation that can cause long-term complications such as reflux, it can cause long-term problems related to the reflux, like adenocarcinoma, Barrett's. I don't think it's fair to submit all these patients to this long-term risks. So I think average best risk-benefit ratio is the gastric bypass.
Okay. Thank you so much. Professor Chevalier, your time. Convince us that one anastomosis gastric bypass is the best bariatric procedure.
Well, after having been studying this operation since 13 years, I found that it's a short and efficient operation. It's three short steps: choosing the bowel, bringing up clockwise 1.50 meters if the preoperative BMI is under 50, 2 meters if it's above, and then creating a long and narrow gastric tube and doing a linear stapled gastrojejunal anastomosis. It lasts around one hour. It seems to be efficient in the long term because we've been studying it. At 10 years, we have an excess weight loss of 77%, and the results in the literature seems to be the same in the meta-analysis done by Ifso task force. It's been confirmed. The two principal critiques seems not to be confirmed by our review about the potential bile reflux and limb length problem. The potential bile reflux is not that much. We had to reoperate 1% of the patient, 19 out of 1,585, for intractable bile reflux 2 or 3 years after. So it's not that much important, and it's confirmed by other series in Italy or India. So bile reflux is not a problem if the tube is long and narrow. And, well, the principal problem is limb length, and it's obviously the malabsorptive part of this operation that has to be correctly treated. That's what the recent prospective randomized trial from France, E-omega, showed that it's if you use a 2 meter long, then you can have nutritional problems. So 1 meter 50 is enough. So if you use 1 meter 50, and if you do this anastomosis correctly, it works very well in the long term. But we need further study, and that's what we have now, more than 100 cases that are more than 10 years of one anastomosis, and we will tell you in the next future the results of that. Thank you.
Thank you. Amador, that's not a easy task for a young surgeon as you, but you are here defending one anastomosis duodenal switch. So, Amador, why this procedure is the best one?
I don't know if it was done intentionally or not. I am the younger senior defending the younger procedure. I have two big handicaps. First of all, CEDIS is still considered an experimental procedure by several societies. Second one, the first CEDIS procedure was performed just 12 years ago, so we are lacking of long-term results. But we come from big experiences with duodenal switch. We all know that duodenal switch is the BPDDS as the best procedure ever in terms of long-term results, in terms of long-term comorbidity resolutions. It is safe. We have all the experience from the Canadian surgeons with long-term follow-up, very, very good and results in terms of safety also, not so high malnutrition problems, not so high deficiency. And with the CEDIS, we are adding technical advantages. Everybody thinks that the main problem technically is dealing with the duodenum. I really think the main problem is dealing with the Roux-en-Y anastomosis in duodenal switch. So we are lacking of this problem. We are simplifying the procedure. We have a very straightforward procedures. We have the benefits from the sleeve gastrectomy in terms of eating tolerance. We have the benefits from the malabsorption in terms of we all know when performing the CEDIS where are we living to absorb nutrition. We are having two different configurations, 250, 300 centimeters. 300 centimeters seem to be safer in terms of malnutrition, in terms of reparation rate for protein malnutrition, and 250 is safer, is better in terms of weight loss, especially for patients with higher BMIs. I think it's the best procedure, but it's not a procedure for every patient. We have to consider patients with good follow-up, and patients who are going to be confident with us, a patient who is going to come back to our consultation in order to have a proper follow-up.
Mother, thank you. You did very well. So now, Professor Grieve, of course they are here to show us the best aspects in the different procedures. I want from you and Professor Prager and a vision about the different presentations, the performance of our faculties, and what is wrong, what is the worst part with each of these procedures we just discussed right now?
Well, to start, I have to mention that I'm, of course, a little bit biased, but because I'm really a believer in the gastric bypass and then the banded bypass as a fact. I think the argument that we have on the gastric bypass is quite strong because it's really an operation that has been around for a very long time, and even in the one anastomosis and the duodenal, the SADIs, it's still working on what the operation should look like. There is the risk with malabsorption, and that is one of a big concern because many of the patients, although we really like them to stay with us for the long-term follow-up, they tend to, when they are happy and everything works fine, say, okay, I don't go back to the doctor and come back with severe deficiencies. And that are issues that we really should keep in mind, although that's also true for the bypass. Even in the bypass you will have long-term deficiencies. So the fact is that there is not a very convincing winner in any type of contest for which kind of procedure. And one thing we should also take into consideration is the surgeon experience. I think when you're very experienced in doing sleeves, maybe that is the thing you should do. On the other hand, when you listen to the presentation of yesterday and you have, after 8 years, a 70% weight regain, that's a concern. The reflux in the sleeve is a concern. We really don't know what's going to happen on the long term in one anastomosis. I mean, we know from the past, and I'm getting to be an old surgeon already, but in the past we did do quite a lot of patients that got gastric cancer after the typical B2 anastomosis. And of course we don't know if it's comparable, but that took also more than 20 years to develop the problem, and we are treating very young patients. So I think there's the perfect operation doesn't exist, and we should all be working on getting the optimum procedure, and it can be in different types. It can be the bypass, but it can be maybe a sleeve as well, and we can solve the problem of the reflux. David, you got a big meeting coming to try and solve that. So there's many things to consider. For now, for me, the bypass is I think, because we know best what's happening, is the operation to go for.
We can see that one of the arguments from that surgeons that defend a lot sleeve gastrectomy is that that's the surgery that you have a second step to offer to the patient. And yesterday we had a presentation from Professor Nasser Sakran from Israel saying that the result of the revision of the sleeve gastrectomy is not so good. So I think that this is another argument that we have to discuss. Gerard, what do you think?
One remark on that, because the sleeve is not really, it is not reversible at all. You do a final procedure, you take that stomach away. When you get another problem in the stomach area, in the esophagus, you really have a problem. I mean, you can't do a sleeve or a tube replacement of the esophagus, for example. And it's a fact. But also in the bypass, when you have a failure of a bypass, it can be quite a challenge to get the patient back on track. Sorry.
I think in the last years things have changed a little bit. I think that all these operations, by the way, I do myself perform all these operations, they do have a place in the armamentarium. I give an example. In the super obesity, you might not have enough weight loss with a normal Roux-en-Y gastric bypass, or even super obese patients. And what in my opinion has changed a little bit in the last years was the detection of the BP limb. Lengthening the BP limb, you of course have better weight loss. On the other hand, it's a dangerous game when you go below 250, 300, some claim even 350, 400 centimeter of total elementary bowel length. You increase the risk for protein malnutrition and even liver failure. And I think we all have to keep that in mind, especially when you look at revisional procedures, when you want to distalize. Concerning the procedures as primary procedures, I think you have also to take into account not only the body weight from the beginning, but whether there is diabetes or not, whether there is reflux or not. Here clearly, in my opinion, sleeve is not the way to go, maybe also not SADIS is the way to go, or even one anastomosis gastric bypass. Here, in my opinion, clearly the Roux-en-Y gastric bypass is the best operation. But overall saying, I think all these operations have their place in the bariatric armamentarium.
So which one is a good patient for a sleeve gastrectomy in your mind?
A patient that has a job that should not develop hypoglycemia, maybe an older patient, let's say 60, that should not experience an excessive weight loss, depending also maybe of the lifestyle, maybe a patient with lower compliance, maybe a patient that has to take some medication where you must monitor the levels, maybe a patient that has had multiple prior operations. These are usually the patients I go for a sleeve gastrectomy. It's in my hands around 14% of my operations. For the super obese nowadays, I go directly for a SADIS. In very rare cases, I do a sleeve and do a two-step procedure. But that, to be honest, we changed that because I'll tell you why. If you're able to go to the angle of his, then you're able, and I totally agree, to do the duodenal anastomosis. So the hardest thing in these super obese patients is to make the sleeve properly. That's much harder than doing the duodenal anastomosis, in my mind or experience.
David, I will do some comments, and you comment after. So no matter we like or not, sleeve gastrectomy represents now 60% of the worldwide bariatric metabolic surgery. Very experienced surgeons, and we have some of them here, are anticipating in the best prognosis, no matter the reason, about 30% reoperation rates, and the more pessimistic are betting sometime around 60 to 70% of revision in sleeve gastrectomy. Some articles are calling for the right risk rates for reflux and Barrett, and the consequent augmented risk of esophageal cancer. So this is a table with the number of procedures in the United States. In the total, we have 624,000 procedures, more or less. And if we are talking about 30% reoperation rate, that some surgeons think will be the minimum, we have almost 200,000 revisions. And if we go to 60%, will be the double. So these are very impressive numbers. We have articles showing the risk of cancer. Again, this is study from Janko, and we have the study with Professor Prager here that we had the same. It's about 17% risk of Barrett's in these patients. So David, are you not afraid sleeve gastrectomy can affect over time the reputation of bariatric and metabolic surgery? And how we will have to explain the number of this reoperation to our peers, our colleagues, the insurance company that is paying for the procedure, the media that is interested in bariatric surgery?
No, I'm not really afraid. Yesterday we had the discussion with Gerard. I think we have a possibility to treat the reflux with PPI, and PPI is working very well. When you have a failure of PPI, you can move to a bypass and then solve the trouble. As I told you, the three articles that have emphasized the rate of Barrett's, I think there is a lot of bias, even if I'm sure that we will increase the rate of reflux after sleeve gastrectomy. People in these studies at 5 years, they came back to the follow-up, and when you came back at 5 years to a follow-up in bariatric surgery, most of the time is because you have a complication, GERD, or not enough weight loss, or something like that, in France. Not in Switzerland or in Sweden, but in France it's like that. At 5 years, when you are okay, most of the time you stay at home. That's a problem, so to have good study in France. Concerning the reoperation rate, first I want to tell you that you mentioned that sleeve is the most performed procedure in the world. Why? Because I think that a lot of people are thinking, as me, that it's the best operation in terms of balance between benefits and risk. GERD is not a big issue. We can manage GERD. Internal hernia, hypoglycemia, several nutritional deficiencies probably are more difficult to manage. So I'm not afraid about to explain to other guys that we have a rate of reoperation, because obesity is a hard disease. For me, I'm doing the parallelism with cancer and obesity. When you have a cancer, you may have reoperation.
Yeah. So, Grief and Prager, we have some surgeons as very experienced as you, as we have here Professor Suter, Professor Chevalier, and it's common among these surgeons very experienced that they are not really in favor of sleeve gastrectomy. But no matter that, sleeve gastrectomy is 60 in the next estimation of procedures in the United States will be probably 65, 66, continue increasing. So why, even that the surgeons are not so in favor, the experimented surgeons that are training the young are not in favor, sleeve continue rising over the world?
You first. Yeah. I steal all the argument.
I think it makes a big difference where in the world you're looking at. For instance, in Europe, in countries with a very strong public healthcare system like the Scandinavian countries, the percentage of sleeve is much different, and that might contribute at least a little bit. I can remember the band story. The band was decreasing in Europe, and we all knew that the long-term results of the band were not that brilliant. And the band was approved in America, and what happened? It skyrocketed. And maybe we have a similar situation right now. This could be, in my mind, one reason. Just to answer David, in our paper, many of these patients were lost to follow-up. We really had to search them, number one. Number two, we gave the length of the CLE, but the reviewers cut it out. But we have these data. Just.
Well, when you look at the Dutch situation, it's quite similar to the Scandinavian. We had a lot of clinics that only did sleeves, but now in time with the experience growing, they are changing back to bypass. And that's not without a reason, because they see many patients coming back with weight regain, with other issues. I do sleeves, of course. Patients ask for it. They say, I don't want to have any hassle with my bowels. Okay, so we do a sleeve, but I advise them on the risks of both the sleeve and the bypass, of course. So we do very limited, in my hospital we do very limited number of sleeves. And in the Netherlands, as I mentioned, it's going down. And I agree, maybe the sleeve is the new band. So, but we see what happens in the near future.
That's interesting. Let's move a little, and let's involve now Professor Suter again. Michel, the gastric bypass is a surgery with more than 50 years of history, and from 1980 to 2010 was considered the gold standard in bariatric metabolic surgery. And it's interesting because right now we continue with this kind of talk that the gold standard, but every Congress we are starting discussion looking for the new gold standard. Look like that we are trying to move from gastric bypass to other procedure, and depend how we interpret it. If we interpret gold standard as the number of procedures, we should consider sleeve gastrectomy as the gold standard. But over time, we have a lot of recidivism, complication rate, nutritional deficiencies, internal hernia, have been collaborating to decrease the grade of confidence of the surgeon about the procedure. This is a Brazilian study. You have what they call weight recidivism in blue for morbid obesity, in red for super obesity. And we can have even worse scenarios if we go to Nicholas Christo study. You can see in super obesity, 10 years after the procedure, 58% of weight recidivism in these patients. So this is the time for a renewal, a reinvention, looking to a more modern version of the Roux-en-Y gastric bypass, with a more metabolic concept of the procedure, increasing biliopancreatic limb, decreasing common limb, measuring out the length of the limb in every patient, ensuring the closing of the spaces. So what's the plan, Michel, that the surgeons that defend Roux-en-Y gastric bypass, they have to overcome sleeve gastrectomy over time? Because no matter what we think, if we go to numbers, sleeve gastrectomy continue increasing, Roux-en-Y gastric bypass continue decreasing. In the table of bariatric procedures all over the world, we have increase of sleeve gastrectomy, one anastomosis gastric bypass, and revisional surgery. All the other procedures are decreasing.
I agree, and it is a problem. We have learned over the years that the BP limb is probably the most important one, except for the common limb. which is relatively long in the Roux-en-Y, in the standard Roux-en-Y gastric bypass. And there are a few studies showing that apparently elongating the BP limb increases the response for diabetics and increases weight loss in the long term. But we don't have many studies showing that. That is still, I think, controversial in some way. So one way probably is to study this in a more scientific fashion, probably multicentric, and really set up studies. Problem with bariatric surgery that before we know the results, we'll have to wait another 5 to 10 years. But I think if we start now, at least in 10 years, we'll know. I said before, gastric bypass is a great procedure. It's probably, there's no best procedure, and in super obese patients, super obese patients, even I also always counsel them that they are better working procedures, sometimes done in 2 stages, sometimes in 1 stage, with also more side effects, more threats regarding the risks of malnutrition and deficiencies. And I have to tell you that half the patients, at least, if not more, still elect to have a regular gastric bypass, despite the fact that they know that their weight loss will be less, but they don't want to go into the trouble of having bowel movements too often a day, too many deficiencies, and other risks. So again, it's a matter of risk-benefit ratio for the surgeon, but also for the patient. And many patients still elect to have a gastric bypass. The super obese patients are often offered them a sleeve first, with the option to go to a switch or a SADI later on. Not many people elect to have this. I may be biased in the way I explain to the patient. I try to be very honest, but of course, with a long and large experience in gastric bypass, I'm probably a little bit biased in the way I tell my patients, even involuntarily.
Okay, thank you. So, Jan and Gerard, you said that you prefer Roux-en-Y gastric bypass. And I know that you work in an institution that you have education, you educate residents, other doctors. So why you and all of these surgeons that are working in educational programs are not convincing the young surgeons that Roux-en-Y gastric bypass is the best procedure? Because these guys go learn how about doing a gastric bypass with you, but go back and continue doing this sleeve gastrectomy.
Well, I don't agree, because the people that are trained in our center, most of them go on and do gastric bypass. And some of them continue to do the banded bypass that we do. But no, we learn them what we are good in, and they take it home. Maybe one comment on limb length and things like that. I think that biliary limb apparently, certainly on the short term, is important, but we have to realize that even in the excellent study that was done in the Netherlands, where they did a 150 biliary, 75 common channel, after 2 years there was a big difference. But when you go to 4 years, the difference is gone. And the same has happened in the past with the longer or the more distal bypass. Well, initially you get a better weight loss, but in time, adaptation of the patient, adaptation of the bowel, the difference is gone. The weight loss is similar. So we have to be very careful not to start moving around with the bowel too much in an operation that in most patients will work, and not create situations where it's dangerous. And I think that the concept that was proposed by Numeri on the total elementary limb length, which is the common channel and the elementary limb length, is something to really keep in mind, because you need to have at least 2.5 meters of total elementary limb length to be sure that you don't come into a situation with severe malnutrition, protein malnutrition, etc.
In Austria, the situation is different. The most common operation is the Roux-en-Y gastric bypass, followed by sleeve gastrectomy, and pretty close one anastomosis gastric bypass. So a very special situation, but I think that all these three procedures have their place. Concerning the total elementary limb length, I absolutely agree. In my experience, I would even go further. I strongly believe that 250 centimeter is not enough. I think that 300, if you have a common channel of 300, is okay. But if you have elementary limb and common channel, there will be patients with a total elementary limb length of 300 that run in the long-term run into severe problems. And I remind you, for instance, in the Belgian paper about 11 patients that were listed for liver transplant after BPD. So this is of concern, and if you are not able, or if we are not able to follow patients with malnutritional, malabsorptive procedures to a high degree, this could also harm the reputation of bariatric metabolic surgery.
Let's have this more clear, because I think it's very important.
I think that, and that is something that Nicolas Copenara has been telling us all his career. When you do gastric bypass, major part of it is restrictive, and when you combine that with malabsorption, then you're really in dangerous area.
So Gerard, you talked about 3 meters, 1 meter, 75. Let's have clear for these guys here how to measure, because I wanna thinking about doing a study to have in my surgical room 3 surgeons, and we will try to measure the bowel. I'm very confident that we have a big difference in the 3 surgeons measuring the same patient at the same time. So how to measure at first, and at second, how do you use the numbers? How do you calculate biliopancreatic, alimentary, and common limb?
I can tell you the way how I measure, but I'm convinced there is no best way to measure. I use soft small bowel clamps. I measure antimesenteric and I gently stretch, gently. It's very important. I am always a little bit hesitant to recommend to measure the entire small bowel in all patients, because coming from an academic institution where many young surgeons learn, I can promise you, when you recommend that in all your patients, and you have a patient with BMI 60 male, then you will end up with a certain degree of small bowel leaks, only coming from measuring. Why do I do 5 centimeters and not 10 centimeters? Even if you have a 1 centimeter mistake with 5 centimeters, it's 20% difference. With 10 centimeters, it would be only 10%. But with 10 centimeter measuring, you increase also, of course, the pressure and the way you manipulate the bowel. There are other ways. You could throw in a ruler to the abdominal cavity. You could use a thread that is fixed. I do it with small bowel clamps that are laser marked, so I really know where the 5 centimeters are. And it's also, I think, a kind of, it must be reproducible for yourself.
So let's imagine that from the point you will start measuring at each 5 centimeters, beginning in the triangle, going to the second, how long takes?
This depends a lot of the experience of the surgeon, and I can tell you there are patients where you even touched, I mean, you all know, all experienced surgeons have had this situation. You just touch the small bowel and you see a serosal tear. So sometimes it goes pretty fast. I would say maybe, I never looked at the watch when I did it, but maybe 7 minutes, 8 minutes, something like that.
But it can take 20. In this case,
absolutely,
you have a big liver, a lot of fat.
Absolutely, and then you have a very bad feeling because you think, my God, hopefully I did not make a hole to the small bowel. That's at least my experience, but maybe I'm less skilled than others. I mean, that can be true.
So for that surgeons that used to spend 1 hour to do the procedure, you think that it's reasonable to add 20 minutes in the procedure? There is benefit to the patient about measuring out the length of the limb?
This depends, I think, a lot of the way how you make your gastric bypass. If you make it a long limb Roux-en-Y gastric bypass, the classic one, which means you make 150 centimeter alimentary limb and 40 to 60 centimeter biliopancreatic limb, I don't see any benefit in measuring the entire small bowel length. But if you increase your biliopancreatic limb, and especially if you increase it beyond 150 centimeters, I think there is increasing data that you should measure the entire small bowel. Why? We know pretty well from, for instance, Roberto Tacchino's last paper that the mean small bowel length is 6.9 meters, but it ranges from 4 meters to 10 meters. And when you have a patient with 4 meters and you exclude 200 centimeters for the biliopancreatic limb, you end up with 200 centimeters of small bowel in the food stream. And this means, in the long-term run, protein malnutrition and liver failure. And I have seen, and this is the big problem now when we discuss that, I've seen patients with more than 3 meters of small bowel in the food stream that run in the long term even to protein malnutrition and liver problems. So even if we measure, it is not 100% secure to predict that there won't be any problems in the future, unfortunately.
Well, I totally agree. I measure also antimesenteric, not too full stretch. I use 10 centimeters, but I really measure 10 centimeters. You have a lot of surgeries that just do, I know this is 10 and go on. I don't think and it's reproducible for myself. And I think that when you do a standard bypass where you have a 120, 150 elementary and up to 60 centimeter biliary limb, there's no worry. But really when you go down, and I fully agree on that, you need to know the total length.
This is a difficult subject because I'm sure that if we as Ifso, we say no. For now, we will advise every surgeon to measure the total limb of the lens in every patient. This will increase mortality of bariatric surgery worldwide.
We shouldn't do that. When you do a standard bypass, with up to 150, 75 something, that's okay.
Let's continue.
But beyond that.
Let's continue with Professor Chevalier.
One
okay, sure.
The bypass program.
Just a short comment. We don't need to measure everything, but if we have a longer BPLM and we make sure that's at least 250 or 300 below, we don't need to go to the Ifso-Ec valve.
Go ahead.
Do you
sleep?
You say that
I was sleeping a little bit. So.
We should not measure.
No. I'm doing some bypass too. But do you consider that when why is a standardized procedure? Because no, it's normal. You don't know what you have to do with the length of the stomach. You don't know what you have to do with the length of the bowel. You don't know if you have to put a band or not. So answer to me.
Only for the ear.
Professor Chevalier, look, the one anastomosis gastric bypass took 20 years to start a consolidation process as a recognized bariatric metabolic procedure. And looks like the more recent literature has become in with a more negative data about the results of the procedure. More ulcers, more malnutrition, internal hernias. What can we tell to that surgeons that are a little confused concerning this technique? Look, we have some studies with have here some complications, as you can see, reversal, reoperations, nutritional issues, and I think that the last one is the famous French study. So let's see what are your thoughts regarding that. But we have positive issues. If so approved, reviewed consistently out the literature and approved as a primary procedure. And as you can see here, the number of complications are not so different than the regular Roux and I gastric bypass. So what is your opinion about that?
I completely agree that the history of the one anastomosis was not considered as fairly as the history of the sleeve gastrectomy, because the sleeve gastrectomy was completely widespread in more than 10 years, and without knowing anything of the long-term results, and without asking to the experts to do experimental studies. And when I began studying the one anastomosis bypass, I was considered as a killer, because there was a risk of cancer because of bile reflux. And when I saw the literature, I saw that this principal concern was related to the character of the pioneer of this operation. So I said we need to study this operation. And so that is why we began experimental studies in rats, in order to have quicker answers to this problem of reflux, of course. But why has it not been done for the sleeve, for example? Because now we know that there is Barrett ulcer in long term with the sleeve. Why there has not been these experimental studies in rat for the sleeve also? The principal concern now with the one anastomosis is about limb length. And when the trial, the French trial of E-omega began, Maud Robert, who was the principal responsible, decided to do a BP limb of 2 meters, because it was the regular one published by Routledge and others, because it was supposed to be 1/3 of a total limb length of 6 meters. And at that time, that's around 4 or 5 years ago, I was studying 1.50 meters, because I thought that 2 meters was too much. And I told that to Maud. I said, if you do 2 meter bypass, you will have nutritional deficiency. And that's exactly what occurred, which is a good thing, because now it's a good message to say that 2 meters could be too much. But I think we need further studies, but all this has not been considered fairly. In our experiment, we're still doing rats, and we are doing one anastomosis, and we are doing also sleeves on rats, and we have Barrett's ulcer also. So this experimental study has to be done for every bariatric surgery, to study as quickly as possible the results of this surgery.
Thank you. So, Jan and Prager, at first declare your compliance with this technique. You do some procedures? You do one anastomosis gastric bypass or no?
Yes, we do one anastomosis gastric bypass, but I limit it to patients that are 50 years and older. Because I really am still concerned, and we don't know the data on that, what's going to happen with 25 years of chronic reflux in your gastric pouch. But we do, and I think it's particularly in a male patient with a huge abdomen, it's a very good operation to do in one operation everything you need to do, and it has good results, of course. Just to reflect on your thing on testing on the gastric bypass, I think you're wrong, because the gastric bypass has been tested for 20 years before we found the final construction. It started with the horizontal pouch, the loop bypass, and it started in the early 60s. I mean, it's not an operation that has not been proved in time, but that was by trial and error. And of course, in the modern time, we're more going for what you're doing very nicely, experimental studies in animals. But you still need the experience in people.
Gerard, which is your technique for doing a one anastomosis gastric bypass?
I do it since 2011, and I also started with 200 centimeters. And therefore, I understand why, when they designed the E-omega trial, they took 200 centimeters. Why did I start with 200 centimeters? Because at that time, from the published literature, you seem to be on the safe side concerning malnutrition. What I saw myself is, with 200 centimeters, you will have some patients running into problems. And I was very offended for presenting this at some club meetings. I went back to 150, and with 150 you are on the safe side. I think this operation has a place in the armamentarium. How do I do it? I do it a little bit different. I try to make a very long and very narrow pouch on top of a 12 millimeter bougie. I do a 30 millimeter linear anastomosis. Others do 60. I think 30 is enough. We do not see stenosis, and with 30 I lose less length of my pouch than if I would do 60. If I do 60, I lose another 3 centimeters of my pouch.
Where do you start the pouch? What is the point of the stomach you start the pouch?
In former times, we went directly at the level of the cross foot. Now we even try to go a little bit below. We always use at least 4 60 loads to create the pouch. Saying this, this sounds now very, very long. There are some patients, when you later on gastroscope them and you look at the real length of the pouch, you think, wow, this were 460 load, this looks shorter.
Yeah.
But this is my experience. Maybe others have other experience.
So in endoscopy, maybe 1 year and a half, 2 years after the procedure, we'll be with 12 or 15 centimeters, no more than that. We'll
I agree,
short.
yeah.
We will short over time. So Amador Garcia, let's go back to SADIS. You worked and you have some studies with Sanchez Pernot and Antonio Torres. And what I think in the history of the SADIS, you started doing the procedure, and if we look for the literature, in 2010, Sanchez Pernot published with 200. In 2015, increased to 250. And now there is the last study from Torres in 2017 talking about 300. So, what do we have to do? Is 200, is 300? How to choose the common limb in the SADIS procedure?
Okay, it's as I told before, the SADIS procedure has only 12 years. First cases were done in 2007. So the first cases when Sanchez Pernot designed this procedure were done to 200 centimeters. The first 50 cases, they had 8% of conversion due to severe malnutrition. So they changed their mind, they saw that it was too short, they moved to 250, and they had only 1.3, 1.4% of severe malnutrition going to surgery again. At the time, we compared our experience with duodenal switch in Belviche, in Barcelona, and we performed our duodenal switches with a 300 centimeters alimentary channel, 200 centimeters of Roulim and 100 centimeters of common channel. With these measures, we had no conversion due to malnutrition. So when we decided in Barcelona to begin doing SADIS, we decided to use this length. We decided to go for 3 centimeters. What we are seeing now is that this 3 centimeters measure is safer for the patient. We have no patient conversion, no patients converted due to malnutrition, but we are lacking from some failure to weight loss, especially in those patients with the higher BMIs, especially from BMI over 55 and above. So what I have actually talked with Andres and Antonio is that they are dealing, depending on the patient, with the long length. They are not going below than 250. They are reserving the 250 for the higher BMIs, the most confident patients, and they are reserving 300 centimeters for lower BMIs and patients that may be not so confident in the follow-up.
Okay. Your experience with this procedure?
Well, we do the occasional conversion of sleeve to a SADI, and we started with 250, but now I think we need to move to the 3 meters, believing in the total elementary limb length thing. But it's only a few that we do, and it's still, of course, a technique that needs fine-tuning. How big should the sleeve be? But there's also some discussion on the size of the sleeve. Is it a wider sleeve? Is it a very narrow sleeve, etc.? So I think there's a place for this procedure, in particular in treating patients with a failing sleeve, but certainly not for all the patients.
I had the opportunity and visited Antonio Torres in 2016 and started doing SADIS thereafter. And to gain experience, we only did it in super obese patients. I started immediately with 300 centimeters, and my reason to start with 300 centimeters was that I'm more afraid of malnutrition than of insufficient weight loss. And my concept is that if with 300 centimeters a patient does not lose properly weight, you still can convert him to a classic duodenal switch. So from my point of view, I'm on the safe side with malnutrition and liver problems, and still have the option to go for a classic duodenal switch.
Well, there's another argument to take into consideration. I mean, there are regions in the world where there's no access to all the supplements that you really need in this kind of malabsorptive operation. So I would be very reluctant in a patient that cannot afford to buy all these supplements, or is in a region where you cannot get access to it. But on the other hand, it's potentially it's a good procedure.
So Yuri,
I perform SADIS procedures for 5 years, and we are in a good communication with Antonio Torres and exchange information about results, about nuances. So my opinion is that 250 centimeter for SADIS procedures is rather standard and is very optimal. Why? First, there is 50, 70 centimeters additional for absorption in a biliopancreatic limb. Yes, so de facto there is not 250 but 3 and even more centimeters in standard procedure with 250 SADIS. First. Second, I have previous experience with duodenal switch procedure, and we now are working to compare results, long-term results of two procedures. So the weight loss, excess weight loss, 3-4 years after both procedures is inferior to duodenal switch, because after three years excess weight loss is decreasing, and there is a clear tendency. And there are some patients with diabetes mellitus who became diabetic 3-4 years after SADIS procedure. So there is we see that anti-diabetic effect of SADIS is some less than in our previous experience of duodenal switch. But we continue to use SADIS and plan to remain 250 as a standard procedure, but I agree with my colleague that in some patients 300 centimeters is more acceptable. Yes. Then advantages are, so we almost avoided internal obstructions, small bowel, late small bowel obstructions. The cases of protein malnutrition, I know only 2 patients who have it. So, and SADIS has more mild effect in comparison with duodenal switch procedure, but weight loss is almost the same, at least at 3 years.
thank you, Yuri. So let's see a clinical case now to try to understand how do you think. So we have a male patient, 47 years old, BMI 45, obesity since 27 years old, after marriage. As some of us used to be an athlete before marriage, high blood pressure using losartan, dyslipidemia using rosuvastatin, no smoker, 6 beers a week, 2 bowel movements a day, gastroscopy with a light gastritis, ultrasound with a light steatosis, and this patient is cleared by our multidisciplinary team to do a bariatric surgery. So, David, you agree with the indication for surgery of this patient, and which technique you should recommend?
No, I'm not agree. He has to divorce. That's my feeling. No, I'm totally agree with the indication for surgery for sure. When a male was active and is less than 50 years old, it will be a good indication and good prognostic to have a good weight loss in the long run and efficiency operation with sleeve. I don't see we have no GERD before.
No GERD.
So, to be honest, today I'm still proposing it as a Nissen sleeve for this type of patient too, because we know the de novo rate of GERD after. So I think sleeve or nascent sleeve if we can prove in the long run that it works. Okay.
But you recommend for this patient a nascent sleeve, even with no reflux?
I'm doing prospective evaluation because I'm so happy with the results of weight loss. Because at the beginning of nascent sleeve, people told me you will have less weight loss because you let in place the fundoplication, you will have trouble with ghrelin and everything, blah, 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 blah. At the end of 3 years, I have the same weight loss than sleeve. So, same weight loss, less than 10% of reflux and no more leakage at the east angle. Today, on my end, in my team, I can propose this, okay? But for the other, I think they have to have a learning curve and to wait for a little bit. I think 2 years it's enough to, at 5 years, we can say that it's good, okay?
Chevalier.
Yes, well, of course, I agreed to operate him because he is in the regular guidelines of this surgery. I'm just a bit concerned of the 2 bowel movement per day. Is there a reason, especially for that? Because it's a bit.
Oh, you
speedy.
study the patient. You have colonoscopy, no colon disease.
So it's important not to increase this problem afterwards. So maybe. We should. If I do one anastomosis, I will measure the total limb length in this case to be sure to have a good bypass, but not too much.
So what is good and not too much?
Yes, well, 1/3 of the total bowel length. Yes, and be sure to have 3 meters downwards, because same.
Okay, Amador.
I fully agree with the indication for surgery. I will discuss with the patient for a SADIS with 300 centimeters common limb. And I especially will discuss with the patient his social condition, if he's able to go for good food, a good protein intake, if he's able to afford to pay for all the supplementation he will need in terms of vitamin D, vitamin A, calcium, and so on. If he's able, if he's going to be compromised of doing at least 1 year control with us or with his GP, in case his GP is properly trained for follow-up these patients. In case that the patient cannot afford for supplementation, for good feeding, in case he's not going to be compromised, or he's not going to be compromised with the follow-up, I would have proposed him a SADIS procedure.
I think this is a quite good case for a Roux-en-Y gastric bypass, no, Michel?
I think it's a good case. What bothers me a little bit is the 6 beers a week. I tried to get this patient to drink less alcohol and less caloric beverages, because this is a source of calories that most people don't really need. And apart from that, I think it's a very good indication for surgery, and I think Roux-en-Y gastric bypass will get good results in a patient like this.
But let's imagine that the patient looks for you and say that he would prefer to have a sleeve gastrectomy. Are you agree in primary with the patient, or trying to convince to do a Roux-en-Y gastric bypass?
Well, I'll go a little bit further to make sure he has no reflux, and this patient will get a pH study. But if there's no reflux, I see no reason why not to perform a sleeve at the present time.
So I think this
but
is
I warn him against the risk to develop sleeve in the future.
a good entrance for you, Prager. How to study this patient to be sure that doing a sleeve gastrectomy in a patient like this, you don't have the risk to have reflux, de novo reflux?
We scope all our patients. And,
okay, but you know, the scope is good. There is no hernia and no reflux.
Yeah, and we take routine biopsies from the G junction in every patient. If you look at the Swiss data, dealing with silent reflux before the operation becoming or getting clinically relevant after sleeve gastrectomy, you would maybe think about doing pH metric studies before sleeve gastrectomy. If you go for a sleeve, you might do a pH metric study before.
For every patient?
Well, I do only 14% of sleeves, and I don't do in every patient pH metric studies at the moment, but I think we have to consider it when we look at the high reflux rate after in the long-term run.
May I have a comment? Because I'm very surprised. You know that 20% of our patients before to surgery had reflux? 20%. And nobody is taking care of that. I mean, not you, but in France, nobody are taking care of this patient. They have reflux, they take PPI and it's okay. They are doing gastroscopy probably once each 10 years, and nobody is taking care of reflux. So I think if we want to push like that about sleeve and GERD, we have to push about GERD and obesity too, because it's a main issue. So you're afraid of PPI treatment and you prefer to do a bypass, but you have 7% of risk of bowel obstruction and reoperation in the long run with bypass. Explain to me the difference in terms of risk. That's why I'm very surprised by your comments. I have a lot of respect for you, you know that. But I prefer to have GERD and PPI than to go in Ireland in vacation and have a bowel obstruction. That's my feeling.
Sorry,
Yeah.
a little bit aggressive. You're too aggressive, of course. But because in this particular patient, the bypass would be ideal. But I agree fully with Michel that alcohol in this kind of patient is really a risk factor. And even for that, you would, when you cannot convince the patient to stop drinking alcohol, you must very well consider to not operate at all, or then do a more safe procedure like the sleeve in that particular patient. Well, they say that it's 6 and they drink double.
So let's move. Another case. Another male, 37 years old, so now BMI 58, a super obese patient. Obesity since was a child, started with 12 years old, high blood pressure, pre-diabetes, dyslipidemia, no smoker, no alcohol, 3 to 4 bowel movements a day, gastroscopy with light gastritis, moderate steatosis, and cleared by a multidisciplinary team for surgery. So, Professor Suter, what should be your choice for this patient?
Well, this is a patient I would present different solutions. One would be a regular gastric bypass with the shortcomings of probably less weight loss, but less risk for nutritional complications, or a more aggressive operation, and that would be, for me, would be a sleeve as a first stage, and then a conversion to a switch or a SADI as a second stage, if needed.
Amador?
Okay, I will be a little bit concerned in this patient about the 3-4 bowel movements per day. I will check if there any condition that may lead to have this kind of bowel movements. And in case there is no kind of malabsorption of bowel complication, inflammatory bowel disease or whatever, I will look for 1-stage or 2-stage SADIs in that case. But considering that if the patient goes for a 2-stage procedure, I will try to schedule the second stage, not waiting for weight loss recidivism or weight loss plateau. I will try to schedule the second stage 6 to 9 months after the primary sleeve.
Okay, well, I think in this case it's really a question of compliance of the patients. We must be sure to be able to follow him. If he's supposed to have a diabetes in a few years. So, well, the best treatment is the bypass. Well, the question is, well, he has three to 4 bowel movements per day, which is quite a lot. So we must not increase that. So if I was sure, I would do a sleeve at first in order to be sure that there could be a second step, that he could be compliant. If not, I would do a one anastomosis bypass is because there is no problem of tension on the anastomosis, which is low down, so it could be okay.
And considering the BMI of the patient, the one anastomosis gastric bypass here will be with a longer limb?
No, well, no, but you are right. It's important to measure the total limb length in this case to be sure. But it's the BMI is above 50. We measure 2 meters, regular 2 meters in that case, because 1 meter 50 could be not enough. But according to the total limb length, it's special case.
So, David, David, okay, go ahead, Michel.
If you have a super obese patient, you say you take 2 meters. Do you make sure you have at least 3 meters downwards?
Yes, of course. That's why I measure the total limb length downwards. Yes, very important.
So, David, I think it's pretty clear that for a patient like this, we can do a sleeve gastrectomy, but will be not enough over time. So, which would be your plan B for these patients? After 8 months, after 1 year, to do the second step, and what kind of procedure will be your second step for a patient like this?
So first and foremost, I want to tell you that for the first time, I'm agree with my colleague from Paris. You know, it's a joke. We still
It's
don't.
French solidarity.
Yeah. No, but for the first time, I'm agree with Michel too. You know, so European solidarity. No, I have to be honest. In Montpellier, we are doing only Roux-en-Y to move after sleeve. We don't have decided to go through SADIs. We are waiting a little bit more, and we are very happy with that because we have seen the change in the technique since 5 years. So we are waiting a little bit more to go to SADIs, and I think we have to check the new bipartition technique. Is very interesting too. So I know that François Lille will evaluate this operation. Bypass, long limb Roux-en-Y bypass after that for us. Even if I'm sure for this patient, I will tell him that the rate of success will be around 50%, 50 to 60, because above 50 of BMI is not so easy to have a success. The other point is that for knees and sleeve, in that case, it may be difficult to perform. Above 50 in male patient, it's a mess to do it. Okay.
If I may add something, this is a patient who's been obese for his entire life, and he's certainly not looking to become a slim person. If this guy weighs like 160 kilos and goes down to 110, he'll be very happy. He'll be rid of diabetes, of hypertension, cholesterol, and that's all he wants. You don't need to go further down, and you also need to take this into consideration.
I think Professor Fried will propose the solution for the case.
I will not. I will raise another question. What I am missing here in the debate now about this particular patient is, for example, why he is male, why he is obese. I mean, he's not drinking. He's having 3 to 4 bowel movements per day. Is he a sweet eater, absolute sweet eater, or is he a volume eater, or is he eating too much fat? You know, I know that the multidisciplinary team preparation is there, the last point, but we don't know anything about it. And first of all, I would, if a patient like this comes to my practice, I would be searching for the nutritional facts and for the others to guide me a little bit more about what procedure may be the best for him.
But Martin, what would be your strategy depending on the diet? I don't know that we really have you can only advise the patient to change the lifestyle and diet, but do you adapt your procedure according to what he's eating?
No,
so when he's a volume eater, you do a different procedure than when he's a sweet eater?
I'll tell you, if he has 3 to 4 bowel movements now, if I manipulate with the bowel and shorten the bowel, I will create probably double of the bowel movements per day in some of the procedures. It depends. I mean, so it is. I mean, maybe restriction for him could be the solution. I'm just saying that I have this is not enough to to assess properly the patient.
No, I agree on that, but then the next step to decide your type of surgery on the type of diet that's a more difficult issue for me. I
think
wouldn't have the solution.
But it could influence A little bit.
But you have to educate the patient and to change the lifestyle, of course. And in this particular patient in our clinic, we would demand the patient to lose at least 5 to 10 kilos before the surgery, and then you have a good option to do a bypass in one stage.
Yeah, I'm not against letting the patient to lose weight. We demand that in all patients, at least from certain BMI.
Well.
Yeah. But I still think that his behavior, nature of his behavior, is an important thing to know about.
Sure.
Okay, so let's finish with a revisional case. There is a female, 48 years old, 46 BMI, obesity since adolescence, with a gastric band 7 years before, with a BMI at the moment of the band 44, now 46. Nadir, 1 year after the band, 27. So was a patient that responded very well for the gastric band. No comorbidities, important dysphagia and vomit related to the band, and the gastroscopy, a severe esophagitis with light gastritis, light steatosis, and again cleared for the multidisciplinary team for the procedure. This is the X-ray of the patient where we can see the port, we can see the band, we can see the stomach, we can see the pouch, and this is the scope of the patient. So, your agreement with the indication for the surgery about the preparation, the technique, 1 or 2 steps. Michel.
Can I ask one question before? Because
Sure.
this patient had a good weight loss and then only comes back for the surgeon with a BMI of 44 in the meantime. What happened in between? Did she never go back to the clinic? Or
These are present for you are patients, are real patients. This patient did the follow-up for 2 years, and after 2 years regarding problems with insurance companies, we lost the contact and just come back in this situation.
Now, in this patient, seems to me that the band is not completely deflated. So before I go back for surgery, I would try to deflate the band a bit or even completely and see what happens. If symptoms persist and the weight remains an issue, then I think it's a very good case for a conversion to a gastric bypass. I would certainly do this in one stage if possible, and it is possible in most cases. And we've shown excellent long-term results with this type of conversion, especially converting a band with reflux symptoms to a gastric bypass makes sense. It resolves both the weight issue as well as the reflux issue.
Which is your strategy, Michel, for doing the pouch? Because I think we can see that we have about a 3 centimeters pouch, and we have the band. The position of the band is a little it's not good. So you go over the band or under the band to cut the stomach, to do the pouch?
In this case, seems to me that there's a hiatal hernia. Yeah. So I would certainly dissect the hiatus, reduce the esophagus, do a hiatoplasty, and then I make my pouch wherever I want it to be made. So if it's below the band, above the band, or at the band, depends on the length of the stomach I want. There's no problem in removing the fibrous tissue that has formed between the band and the stomach in order to start trimming your stomach at the place where the band was.
And you remove the capsule of the band or no?
If I cut where the band was, yes.
Okay. Amador.
In that case, I will be a little bit concerned. Even it's safe to perform a sleeve gastrectomy after a gastric banding and the results are good, I will be a little bit concerned in terms of long-term reflux after or long-term motility disorders of this esophagus after a lot of time with the band. So I wouldn't consider this patient for a series. I would recommend her go for a Roux-en-Y.
Chevalier?
I completely agree with Michel that the first step is to deflate this band and have an upper GI series with a deflated band in order to see exactly what happened, because we cannot conclude on the dysphagia and vomiting if the band is inflated. Is there an achalasia? Is there a dilated esophagus? How is it? And according to the results we had with these with deflated band, I will decide what procedure. Of course, if it is, but it needs a multidisciplinary assessment to know exactly if it is a band failure. If it's a band failure, it's a restrictive failure. So that's a patient who requires a bypass, and the decision of the type of bypass would depend on the upper GI series. If it's okay, I remove the band, and I can do a one anastomosis. But if there is any reason why the esophagus is still ill, then I will do a Roux-en-Y.
David?
I think first I will remove the band, then for 6 months I send to dietitian and multidisciplinary staff, because when you have a band and when you are vomiting, you don't have a normal diet. So after 6 months I will reevaluate the patient, and then two options. The first will be bypass. This is the gold standard for me, a Roux-en-Y for this case. But in the future, I think Nissen sleeve may be a very good option for this patient. The problem when you are doing Nissen sleeve after band removal is that you have a lot of fibrosis, so you have to remove everything. And when you are removing the fibrosis, you're very close to the gastric wall. So be careful, you may have a thermic injury and a perforation. So the two options, I think, bypass or Nissen sleeve. Yeah.
Martin is here to say that you agree with this, no?
I agree with part of the panel. And what I wanted to say is that I think that the band is not dead yet. So where I am heading towards is that I would agree that deflation of the band would be the very, very first case. And I would leave the patient and work with him, because he received or he achieved a very good weight loss result with the band. Then there was something happening he was not attending. So if he's going to attend now, I would stay with an open band, because paradoxically, you see that the more the band is tight, some of the patients gain weight again, because they are trying to get something in. So I would work with him. I would not automatically set him for a reoperation. I would work with the band first. And if I see in a certain period of time, like 6 months, that he's not doing well, I mean, in a sense that he's not losing weight and he cannot readjust his lifestyle and behavioral and nutritional, then I would consider a reoperation and converting to a different procedure. But first of all, I would not remove the band, because I think that it may be a result, the weight gain may be a result of not working with the patient. And all of us who did bands know that this is an essential thing to work with the patient who has a...
So you are afraid of GERD after sleeve, but not afraid of GERD after bending.
Well, I'm a friend of a GERD. I'm a friend of a GERD which can be reduced or treated, and the GERD with band deflation can be treated with the sleeve. No, I can't deflate the sleeve.
Martin, I agree with your idea on the band, but the only thing in this particular patient, as Michel already mentioned, that you do have a hiatal hernia, and probably the band is in the hiatus, and then of course it's
absolutely agree.
It's a problem you can't solve.
I agree, but in that case, the indication of the band was also questionable, because probably the hiatal hernia was there already when the band was placed. But anyway.
But as I said before, working with a patient, you can try it for 3, 6, 12 months, but my experience is that in the end, usually you lose. And in the end, usually you need to do something. So try to have the patient back on track with the multidisciplinary team, with all the discipline that it takes. But once you've done that, I think there's no point in delaying a reoperation.
Your last comments before to close the session.
I would definitely dissect the hiatus. I think this is mandatory in this case. Restriction failed, so I want to have, in this case where you see a lot of inflammation at the G junction, being it as dry as possible. Therefore, in my institution, clear indication for a Roux-en-Y gastric bypass. As restriction failed, I will add a certain amount of malabsorption. We would go for a Roux-en-Y with a 150 centimeter PP limb.
One step.
Yes, definitely. And we always we would make the pouch a little bit longer than Michel, long and narrow, and resect the fibers. In very rare cases, you have a pouch dilatation where the wall is very thin of the stomach. And in these cases, I think a two-step procedure is better, because then, in my experience, you're not able to form a proper pouch.
I disagree with you in terms that I don't think it's a failure of restriction, it's a complication of a procedure. It's not the same. The patient had excellent results early on, before the complication occurred, and it's not exactly the same as a patient who never lost enough weight with the band.
Yes, of course.
Yeah.
Well, I think that I agree with most of the part on converting in one step to the bypass, removing the band, and that, yeah, I think that's the way to go in this patient.
I think you have to acknowledge that pouch size is not that important anymore. We were going for the small pouch 10 years ago, but we now know from single anastomosis, gastric bypass, that pouch size is not important. So creating a pouch in a band conversion, I would always go for the safe side and go for a longer pouch. The only reason you should do it in a two-step if you are afraid of the fibrosis near his, and you are afraid for your vertical stapling, because then you can create maybe a leak. That would be my only reason to do a two-step conversion, and otherwise just go longer and smaller, narrower. Simple.
Well, the surgeon is never afraid, but should be concerned. And I think that when you really dissect, you can take down all these adhesions. The capsule of the band is in general quite easy to remove, in particular when it's very thick.
Catalin,
So that
last
is not
comment.
the problem.
I noticed that it's about to end this wonderful session, and I want to congratulate you for the idea of. But it's time for going for the break. So I want to give some answers. There were some questions here about the. Only 1 minute I'm going to keep you. Sleeve is not experimental. Remember, we have 30 plus years of doing duodenal switch, as sleeve is one of the parts. Remember that we started that it was an incremental procedure, so we split in 2 steps. The explosion of numbers of operations on bariatric surgery we are doing now is because of sleeve. Sleeve didn't steal from one of the other procedures, but added a lot of patients to the hundreds of thousands of patients we're operating now. And please stop of showing some pictures with gastric cancer that occurred in patients. There are only 2 cases. One is esophageal cancer published so far associated with sleeve. One is esophageal cancer 4 months after the surgery. Is it better?
No.
And the other one you are displaying is 5 years after a sleeve. Every year was scoped this patient, and it's a gastric cancer. Is it better? So reflux without hiatal hernia or misplacement of the cardia in the chest does not exist. Sleeve is meant to be a fast emptying stomach, faster than the normal one, so we need to study more. But all the procedures are having their place in armamentarium, and congratulations for this wonderful debate. I wanted to give some answers to something that is very stressful and sometimes offending for those who are doing a lot of sleeves, and I think it's a quite technical problem. It is something with. Thank you very much.
So thank you, Catalin. Look for these guys. All of them, they deserve a bariatric and metabolic surgery, and you can see that they are happy. They are happy with their life. So it's up to us to collaborate to improve the life of these guys and not create problems. And I think that the reason for this session is exactly that, to change experience, because we will go back to our office and we will attend this kind of people. Thank you for joining us in this session. Again, Prager and Dargent, thank you for offer to Ifso the opportunity to have this debate. I think it's very important. Thank you.
Well, Amino, I think that you need to be thanked for this session. It was an excellent idea and a very nice discussion. And I take the privilege to thank with this opportunity the organizing committee of this meeting. Gerard Prager, Ralph Peterly, Rachel Betterham was involved as well. I think we have had a meeting so far with a program that is really outstanding and much better than I've seen over the past year. So congratulations on that and thank you very much.
But it's true.